Buenos días. Vamos a ir empezando esta sesión. Mi nombre es Felipe Atienza, trabajo en el Hospital Grigorios Katsouras de Madrid. Estoy moderando esta sesión con el doctor Julián Pérez-Villacastín, que trabaja en el Hospital Clínico de Madrid. Y el título de la sesión va a ser en inglés, por tanto vamos a intentar mantener los comentarios en inglés si es posible, aunque podemos también en algún momento determinado hacer resúmenes en castellano. El título de la sesión va a ser AF Ablation, Pulmonary Veins and Beyond. Es un placer para mí introducir al primer speaker, que es Grigorios Katsouras, que va a hablar de Multi-electrode RF Balloon Catheter Ablation. Thank you.
Recordar que podéis hacer preguntas a través de la web, del código QR, y las podemos ver aquí y las preguntaremos a los ponentes al final de la sesión.
Okay, dear moderators, dear colleagues, I'm Grigorios Katsouras. I'm working in Italy in Acquavia delle Fonti in Bari, and I will speak for the multi-electrode radiofrequency balloon catheter. I would like to thank the organizing committee for inviting us to present this new technology. I don't have any conflicts of interest. So nowadays we have I'm sorry I don't speak Spanish. Anyway, I can understand something, but I will give my talk in English. So anyway, nowadays we have mostly two techniques of ablation that we use mostly. One is the cryoballoon ablation, and the other is the point-by-point radiofrequency ablation for the pulmonary veins. So of course, there are advantages and disadvantages in every technique. So the single-point catheter, the lesions, the favorite thing is that the lesions are guided mostly from potentials. So we can understand when we have a good lesion, we abate the signal. So we have done our job. We isolated the pulmonary vein. Also, we have also the energy output. We can titrate the energy output according to the tissue thickness of the ablation area. However, there is also this technique is also operator dependent. It depends a lot on the experience of the operator, and the stability of the catheter is not easy to obtain. As you can see here, let me see if I should. As you can see here in this video, while we are looking at the catheter with a good contact force, it seems that it's mostly stable. It moves just with the respiratory movements. If we look in the intracardiac echo, we will see that the catheter is moving. Excuse me, the video stopped. Anyway, we will see that the catheter was moving a lot and not as the catheter was showing. In the cryoablation, the advantages are it's less operator dependent, and we have a stability of the catheter because once it freezes, the catheter is stable. This is the first generation of cryoablation, and this is the second one. That is, we can see that the freezing area is more homogeneously distributed around the vein, while here in the first generation we had just a ring of freezing. However, this is a possible disadvantage of the cryo balloon is that we have the identical amount of energy delivered on the anterior wall as well as in the posterior wall. And as you can see from this image here, the thickness of the wall is different. We have, as we know, the lateral ridge, we have almost 10 millimeters of thickness, while in the posterior wall we have 2 or 3 millimeters. So we have this new catheter, the multi-electrode radiofrequency balloon catheter, which is a spherical 28 millimeters compliant balloon that conforms to varied PV anatomy, and it has 10 irrigated electrodes who deliver customized energy and enabling single shot or single metal ablation. This is compatible with CAR-to-3 mapping system, so can reduce fluoroscopy. And it has also an over-the-wire diagnostic catheter for real-time PVI validation. This is another image of the balloon, 28 millimeters, and we introduced the balloon through this sheath of 13.5 French and with one-way deflection. So we participated in this study, the Radiance clinical trial, which is the first in human feasibility study, a prospective multi-center single-arm evaluation in approximately 40 patients that undergo PVI isolation using this radiofrequency balloon. And we used also the CARTO system while visualizing the radiofrequency balloon with applicating radiofrequency energy simultaneously from all electrodes, 30 seconds in the posterior wall and 60 seconds in the anterior wall. And in all patients, we monitored the esophageal temperature to avoid esophageal lesions. The safety endpoints were the primary adverse events within 7 days, including pulmonary vein stenosis, identified 1 week after. The secondary points were the 30-day periprocedural and 3-month serious adverse events and adverse events, the assessment of PV stenosis, and also the incidence of pre- and post-ablation asymptomatic cerebral emboli, with incidence of new or worsening neurologic deficits. To do that, we were performing a CT scan before ablation and after ablation, and also a neurologic visit from an experienced neurologist. And also, we performed an endoscopy after the ablation to see if there were any esophageal lesions. The efficacy endpoints were the acute effectiveness of the catheter, of course, and then if the balloon was adequate to fit in the various pulmonary veins, in the anatomy of the various pulmonary veins, and of course, if we could manipulate well the catheter to position it effectively. So this is an image of the catheter during the ablation. You see is in the right superior pulmonary vein. We used, there were 40 patients enrolled, but 39 were treated by 9 operators, 5 in the European Union and 4 from the USA. However, all the centers were in the in Europe. That is 4 sites in the UK, Italy, and Czech Republic. In half of the patients, we used conscious sedation, and another 19 patients underwent general anesthesia. During the ablation procedure, we had an interrupted anticoagulation regimen, and we target an ACT of measure of 325 seconds during the whole procedure, and we checked the ACT levels every 15 or 30 minutes. And also, we flushed the sheath continuously with heparinized saline. In order to avoid phrenic nerve paralysis, we used pacing maneuvers during the ablation so as to stop immediately the ablation if we had any indication of paralysis of the phrenic nerve. To minimize the esophageal injury also, we use an esophageal temperature probe or barium swallow, and in some centers also CARTO sound or ice to avoid esophageal lesions. The ablation procedure, before the ablation, we performed mapping with the lasso circular mapping in our center with a 20-polar lasso circular mapping. Then we introduced the multi-electrode radiofrequency balloon catheter, and we ablate the veins as assessed by the mapping study. We used also after the ablation isoproterenol or adenosine and pacing protocols in order to verify the complete isolations of the veins. And after the ablation, we used again the lasso catheter to see the map. Of course, after, as I said already, after the ablation, we had a post-procedure endoscopy in order to see eventual esophageal lesions. The ablation settings were that the power delivery was always in unipolar mode. The flow rate was 5 milliliters per minute, while during the ablation, the irrigation flow rate was 35 milliliters per minute. The power setting was 15 watts. For all the electrodes, the 10 electrodes were in 50 watts. The application time was maximum 60 seconds in the anterior wall and 30 seconds in the posterior wall. These are the characteristics of the patients. 57% male and with an EF duration of 51 months, 52 months almost. Mostly of them were hypertensive. The total procedure time was less than 2 hours, generally. And the number of the applications per subject was 7. That would mean less than 2 per vein. And, excuse me. And the procedural fluoroscopy duration was 17 minutes, while the balloon was, the balloon dwell time was 40 minutes. The PVs were isolated just with the balloon. 100% of the veins were isolated without performing any touch-up ablation with a single-point catheter. Another interesting point was that 80% of them were isolated just with one application. Just less than 5% we need again to go to perform an isolation after we checked with adenosine that there was possible connection of the veins. Low incidence of procedural complications. No stroke, no transient ischemic attacks, no tamponade, no fistulas, no vascular complications. We just had a phrenic nerve paralysis in a patient that was the phrenic nerve pacing was inadvertently not performed during the ablation of the right superior pulmonary vein. So, recapitulating, we had 39 patients that were treated, 100% isolation, 80% with just one shot isolation of the pulmonary veins, 80% of the veins, 40% the balloon dwell time, 70 minutes of fluoro time, and 4.6 reconnection rate. As you can see here, this is the ablation. You can see the impedance that is lowering. We can see when you ablate, changes the color here, it becomes red. And you can see how in all the electrodes we have a good impedance lowering. This is an image before the isolation, and this is after. You can see a nice isolation of the tissue. This is another also image of them, pre and post isolation. And so I would like to conclude here that the radiofrequency balloon could directionally tailor energy delivery for efficient and effective PVI. The acute success was achieved in 100% of patients, and focal catheter touch-up was not required, and the latent PV conduction was less than 5%. No serious adverse events in this first human study. However, we need a confirmatory trial that will be initiated soon to assess the safety and effectiveness of the RF balloon for treatment of patients requiring PVI isolation. And I conclude here with this image of Ithaca and our lab like an orchestra. This is Dr. Grimaldi, who is the main operator of our lab, and these are the nurses and the technicians. This is an image made by a nurse. Thank you very much.
Thank you. Okay, we will have the questions and the discussion at the end of the talks. So we move on to the next speaker. That is Dr. Stephen Williams, coming from St. Thomas in London. And he's going to talk about the strengths and limitations of voltage mapping to identify the substrate of atrial fibrillation.
Okay, thank you, Mr. Chairperson, for the introduction, and thank you as well to the organising committee for inviting me here to this beautiful city to speak today. My name is Stephen Williams, and I'm a clinical lecturer in cardiac electrophysiology at St. Thomas's Hospital in London. These are my disclosures. So today I'm going to discuss the strengths and limitations of voltage mapping to identify the substrate of atrial fibrillation. First, I'm going to review the motivation for mapping the AF substrate, including the emerging voltage-guided ablation strategies. After that, I'm going to discuss the techniques of voltage mapping in the EP laboratory, including the definitions of normal and abnormal voltage and some of its inherent limitations. Given these limitations, I'm then going to try to address the question of whether or not voltage mapping does identify features of an AF substrate. And finally, I'm going to touch on some new techniques that we think could potentially improve substrate mapping in atrial fibrillation. So as this audience will all be aware, the field of AF ablation changed dramatically in 1998 with the seminal observation of the Bordeaux group that atrial fibrillation can be triggered by ectopy arising in the pulmonary veins. This observation led on to procedures to isolate the pulmonary veins from the body of the left atrium in order to remove the trigger for AF. However, whilst pulmonary vein isolation can be very effective to achieve long-term freedom in paroxysmal AF, success rates in persistent AF are certainly more modest. Now, part of the reason for the limited success of pulmonary vein isolation in persistent AF may be that PVI fails to address the underlying atrial substrate. The mechanisms of AF are complex, involving cellular, electrical, structural, and hemodynamic effects. So the aim of substrate mapping, potentially using electrogram voltage, is to identify these features via the electrograms with the aim ultimately of being able to ablate them. Now, in this context, voltage mapping has been used for over a decade to identify diseased left atrial myocardium. For example, in a large study from the Thales group, atrial scarring, defined here as undetectable voltage in the body of the left atrium, was present in a small number of cases, but was associated with markedly increased recurrence of AF after ablation. Similarly, in more contemporary data using high-resolution mapping, the presence of low voltage, here defined as a voltage of less than 0.5 millivolts, was also associated with recurrence of arrhythmia after PVI. The problem with this hypothesis, of course, is that the STAR AF2 trial, published in 2015, failed to show any advantage of performing substrate ablation over and above PVI alone in persistent AF. Now, substrate ablation in STAR AF2 was guided by the presence of fractionated electrograms, not electrograms of low voltage. And it's important to realize that in STAR AF2, no voltage mapping was performed, and so we do not know how the substrate for persistent AF, defined by voltage mapping, would compare between these groups. But overall, there was no difference, as the audience will be aware, in outcomes when substrate ablation was added. Moreover, in an elegant study combining voltage mapping in atrial fibrillation with voltage mapping in sinus rhythm, Jadidi et al. Showed that sites of continuous fractionation in AF, the definition of substrate used in STAR AF2, actually displayed normal voltage in sinus rhythm. Moreover, there was no overlap between AF fractionation and sinus rhythm fractionation. Now, these results suggest that arguably the wrong target for substrate ablation could have been used in STAR AF2 and led to the hypothesis that low voltage, rather than complex signals, could potentially better identify the substrate for AF. Now, one way to test this hypothesis would be to ablate regions of low voltage and to study whether or not this improves clinical outcomes. To date, there have been a number of studies describing low voltage guided ablation. In this study by Rolf et al., they reported a consecutive group of 178 patients and showed that low voltage, defined as areas of less than 0.5 millivolts, were present in 10% of patients with paroxysmal AF and 35% of patients with persistent AF. Furthermore, they reported a voltage-guided substrate ablation strategy in which they aimed to isolate low-voltage areas, either by homogenation or by selective linear ablation, and they showed that success rates were actually similar in patients who had low voltage and underwent additional substrate modification as compared to the group who only underwent pulmonary vein isolation. In addition, they also reported a comparison with a control group who had low voltage but did not undergo substrate-based ablation. And in comparison with this group, they showed that outcomes at around 1 year of follow-up were markedly better than when voltage-guided ablation was not performed. So this is really the main take-home message from this study. However, it's important to note that although these results are impressive, there are some features of the design of the trial that we should recognize. The main point is that the control group were a historical control group originating before the study, which ran from 2010 September to 2011 December. We're not actually told in the study how this control group was selected, and so the results should be interpreted with caution. Now, the same level of caution must also be used to interpret the subsequent 7 studies reporting on voltage-guided ablation, and it is crucial to remember that these are all observational, non-randomized studies. These studies fall into 2 groups. Firstly, there are those studies that simply compared pulmonary vein isolation in patients without atrial low voltage to pulmonary vein isolation plus low voltage ablation if low voltage is identified. Now, these studies typically use an historical control group. Secondly, there are those studies that apply the strategy of voltage-guided ablation to an unselected population of patients, guided by the identification of low voltage or not at the time of ablation. Now, arguably, this group of studies is the more clinically relevant group of studies as it addresses the strategy of applying a voltage-guided ablation. In the first group of studies, equivalence is sought between these study groups with the hypothesis that patients who have low voltage in their atrium would be expected to do worse, and if low voltage ablation is added and the recurrence rates are the same compared to a group undergoing PVI alone, then this would deem voltage-guided ablation to be a success. In the second group of studies, the hypothesis, of course, is that the addition of low voltage ablation would improve outcomes compared to pulmonary vein isolation alone. Now, as you can see in the first group of studies, shown in red, the p-values are all non-significant, indicating that the studies did not identify a difference in outcome between the 2 groups. Remember, of course, that failing to detect a difference is not the same as proving that the outcomes are the same. In the second group of studies, there are conflicting results, with some studies showing improved outcomes in patients with a voltage-guided ablation strategy, and one study failing to show a significant difference. Now, remembering that these are all observational studies, what is really needed here are randomized trials. Unfortunately, 2 were published last year. In the first, Katsouras et al. Randomized 124 patients to standard ablation or voltage-guided ablation in a single-center study. In the standard ablation group, paroxysmal AF patients underwent pulmonary vein isolation alone, whilst persistent patients underwent pulmonary vein isolation plus linear ablation at the roof, inferior wall, and at the mitral isthmus. In the voltage-guided ablation group, all patients underwent pulmonary vein isolation, but patients with low voltage also underwent low voltage area homogenization, linear ablation, or region isolation. Now, patients in the study group did significantly better than patients in the control group, with much lower arrhythmia recurrence out to 1 to 2 years of follow-up. Now, 3 points are important to know about this study. Firstly, the control group did particularly badly with a recurrence of, with an arrhythmia-free period of only 42%, and potentially this might relate to the recurrence of atrial tachyarrhythmias owing to mitral isthmus ablation. Secondly, the primary outcome in this study required patients to be off antiarrhythmic drugs, and the use of antiarrhythmic drugs was not controlled by the study protocol, in potentially introducing a source of bias. And finally, and potentially most importantly, only 16% of patients in the study group actually underwent low voltage ablation. And this is particularly important considering that only 78% of patients in the control group and 88% of patients in the study group completed the follow-up. In the second study, Yang et al. Randomized 229 patients with non-paroxysmal AF to voltage-guided ablation or stepwise ablation. Voltage-guided ablation in this study involved homogenization of low-voltage regions, ablation of complex electrograms at the transition zone, and dechanneling linear ablation, shown in green. Stepwise ablation in the control group, however, involved additional roof ablation, mitral isthmus ablation, and complex fractionated ablation. Both groups underwent pulmonary vein isolation. Now, in this study, substrate modification was performed in slightly more patients, so in 44% of patients in the treatment group. And over 2 years of follow-up, there was actually no significant difference in outcomes. However, the authors report that procedure time was shorter, fluoroscopy time taken to achieve substrate modification was also shorter, and RF energy delivery was shorter. So from this, the authors conclude that voltage-guided ablation, whilst potentially not improving outcomes, may result in better targeting of substrate ablation. Now, given the conflicting results of the clinical trials, 2 important questions arise. Firstly, does voltage mapping actually provide a gold standard definition for the atrial substrate? And if so, under what conditions and with what techniques and with what voltage thresholds should voltage mapping be performed? To answer these questions, we first need to take a look at the techniques of voltage mapping and the data showing what is normal and abnormal left atrial voltage. Voltage mapping performed in the EP laboratory can be performed in unipolar or bipolar configuration. In unipolar configuration, the electrical signal is recorded between a catheter electrode in contact with the myocardium and a reference electrode, which might be Wilson's central terminal or an electrode in the venous system. In contrast, in bipolar mode, voltages are recorded using two closely spaced electrodes, both of which are in contact with the myocardium, and one connected to each terminal of a differential amplifier. The bipolar signal thus created is therefore the difference between these two input signals. Now, bipolar recordings have the advantage of eliminating or at least reducing far-field artifact, but they do record from a larger area of atrial myocardium. Also, bipolar signals tend to be of smaller amplitude than unipolar signals, and this illustrates nicely how the choice of a voltage threshold is crucial in identifying abnormal tissue. To illustrate this, on the right-hand side of this slide are two cases performed in our laboratory. In the top case, there is minimal low voltage, whilst in the bottom case, there is a significant region of low voltage in the septum and also at the posterior wall. Corresponding unipolar voltage maps are shown on the right-hand side, and you can see that when the colour bar is set the same, with a voltage threshold of 0.5 millivolts, the appearances are very different. Now, in all of the studies quoted here, bipolar configurations are used, but the rhythm during mapping, electrode size and spacing, and even the voltage thresholds actually vary between studies. What data are there then to tell us what is normal and what is abnormal left atrial voltage? Well, normal left atrial voltages in apparently healthy atria have been measured in a small number of studies involving patients with left-sided accessory pathways undergoing ablation. As we will see later, it's important to note that these studies use different rhythms during mapping, coronary sinus pacing or sinus rhythm, and also the electrode size and spacing was not uniform between these studies, ranging from 1 millimeter electrodes to 4 millimeter electrodes. As a result, slightly different mean left atrial voltages were seen. Importantly, even in these apparently normal atria, a small number of signals were found to be low voltage, but the definition of normal voltage was relatively consistent at around 0.4 to 0.5 millivolts. In contrast, defining abnormal left atrial voltage is harder given the lack of a histological or functional diagnosis of truly abnormal atrial tissue contributing to the AF substrate. Nevertheless, Sanjay Dixit's group published this study in 2014, where they attempted a statistical analysis for the definition of low voltage. They defined low voltage as the voltage below which only 5% of mapping points occurred. Now, although this study included 20 patients, in fact, only 10 of them had undergone no prior ablation. Nevertheless, with this methodology, they found that voltage varied slightly between LE regions, and they settled on cutoffs for abnormal voltage of 0.2 millivolts for the posterior wall and left atrial pulmonary vein junctions, and less than 0.45 millivolts elsewhere in the atria. Now, this study was performed using point-by-point mapping with the ablation catheter with a 3.5 millimeter tip, and so it's not known whether these voltage cutoffs are directly applicable to mapping with smaller electrodes, as is performed in contemporary mapping studies. Of course, as well as electrode size and spacing, a long list of other factors could also affect bipolar voltage. Now, these factors would include the orientation of the recording bipole compared to the wavefront of activation, the orientation of the catheter tip compared to the atrial wall, contact between the electrodes and the myocardium, filtering of the electrogram, and mapping density and resolution. Now, although each of these factors may conceivably impact bipolar voltage, there is actually surprisingly little data examining the relative magnitude of these effects. Where data does exist, the magnitude of these effects may actually be quite small. Now, next, I'll describe two of these in some more detail. Since bipolar voltages effectively represent the voltage difference between the bipolar pair in contact with the myocardium, the more similar the unipolar electrograms are at these points, the more cancellation of voltage may occur, and the lower the corresponding bipolar signal would be. Therefore, if the bipolar pair is orientated parallel to the activation wave, the wave will arrive at both electrodes simultaneously, and the unipolar electrogram configurations, shown here in a modelling study, would be expected to be very similar. As a result, the bipolar electrogram might be quite small. In contrast, with the bipolar pair orientated perpendicular to the activation wave, there will be a significant delay between the unipolar electrograms, which will appear quite different and result in a larger left atrial voltage. Now, we have tested this hypothesis recently as part of a manuscript in JACC-EP by recording with the pentaray catheter in the body of the left atrium whilst pacing from the coronary sinus or the high right atrium. We paced with an S1-S2 protocol, with the S2 coupling interval reducing from 350 milliseconds to 200 milliseconds in order to allow the effective activation rate to be studied as well. Now, at some sites, the A2 electrograms, arrowed here, showed no change with activation rate or direction. In this top panel, this is coronary sinus pacing, and the bottom panel is high right atrial pacing. And you can see that although the extra stimulus electrograms are reversed in polarity, the overall voltages are very similar. In contrast, here are electrograms recorded from a different site where there was a change. Again, here's coronary sinus pacing, and here's high right atrial pacing. And you can see that the electrogram under high right atrial pacing is significantly smaller than the electrogram recorded under coronary sinus pacing. Overall then, mean electrogram bipolar voltage on a case-by-case basis shows a very close relationship regardless of activation direction. But when electrograms are examined on a point-by-point basis, the association is much weaker. Furthermore, mean electrogram voltage is similar between high right atrial and coronary sinus pacing for a subset of left atrial regions, but different at others, indicating that the complexity of the relationship is high, potentially relating to underlying left atrial anatomy. So these findings suggest that activation direction is an important determinant of left atrial voltage, but that it depends on the resolution that the data is examined as to whether this effect would impact on clinical decision making. Catheter myocardium contact force is another factor where intuitively a high force may result in a higher electrogram voltage. Sasaki et al. Recently tested this hypothesis in a retrospective analysis of ablation points collected during atrial fibrillation ablation. For this reason, there is only a small number of points per case, and they are all recorded around the pulmonary venous ostia. Overall, and perhaps surprisingly, they found no difference in voltage at high contact forces compared to low contact forces. However, when they examined their data split on contact force, they found that at quite low contact forces of 0 to 4 grams, there was a small but significant correlation between electrogram voltage and contact force. In contrast, at higher contact forces, there was no relationship. Now, in order to investigate this relationship between contact force and voltage in more detail, we recently conducted this experiment using a porcine model. Now, to orientate you, this is the right atrium in the pig. This is the region of the SVC, this is the IVC, and this is the coronary sinus here at the side. At each of the sites, marked in red, at the body of the atrium, the junction, and in the venous aspects of the chamber, we recorded electrogram voltage and circuit impedance as contact force was increased using the SmartTouch catheter. In the body of the chamber, we found an initial increase in voltage as contact force was increased before the voltage decreased at higher contact forces. And this attenuation was in line with an increase in circuit impedance recorded with the catheter. Although there was a similar relationship between contact force and impedance at the atriovenous junction, the relationship between voltage attenuation at high contact forces was even more pronounced at these regions. Overall, these data show that contact force does impact on bipolar voltage, but the relationship is perhaps more complex than we would have expected, with an initial increase in voltage as contact forces first increased, followed by a quite markedly reduction in voltage at higher contact forces. Given the complexities and variety of influences on electrogram voltage, it is perhaps reasonable to ask the question, is there actually any direct evidence that electrogram voltage does indeed identify an atrial substrate? And that's the next question which I'll address. The answer, of course, is that there is, although the nature and strength of some of these relationships is rather weak. Nevertheless, low electrogram voltage has been linked to abnormalities in atrial conduction, atrial size and function, atrial fibrosis, and also to severity markers in atrial fibrillation. Let's look at each of these in turn. Firstly, conduction velocity. Well, low left atrial voltage has been associated with increased left atrial activation time in two studies, where left atrial low voltage mean low voltage was lower in sites where activation time was slower. But the time taken for activation will also depend on conduction velocity, but will also depend on the size of the chamber. Other studies have therefore directly assessed the relationship between conduction velocity and low voltage. For example, in patients with SVTs undergoing right atrial mapping, there is a weak but significant correlation between voltage and conduction velocity, with higher conduction velocities seen at higher voltages. Similarly, in a study of 50 patients with quite low resolution left atrial mapping, there was a relationship between voltage and conduction velocity. Overall, these data suggest that low voltage is associated with reduced conduction velocity, although the strength of the data and the actual number of left atrial cases studied is quite small. Next, what about left atrial size? While left atrial low voltage does indeed seem to be associated with increased left atrial size and with increased volume of specifically the anterior portion of the left atrium, whether increased left atrial size leads on to a substrate with low voltage or whether it is a marker of the disease process present, of course, cannot be said from these observations. And then what about atrial fibrosis? Well, CMR imaging, magnetic resonance imaging, is perhaps the only non-invasive method to assess atrial fibrosis. In common use, low voltage is assumed to be due to left atrial fibrosis, and certainly there are some CMR data which do support this relationship. For example, in 2009, Dr. Marouche reported this study, which was a qualitative relationship, not quantitative, a qualitative relationship between low voltage and CMR indices of fibrosis. Similarly, on a point-by-point basis, Malcolm Laws et al., working with us in London, also showed a quantitative relationship between voltage and CMR signal intensity, which flattened out after a threshold of above 5 standard deviations above the blood pool mean. Now, it's important to see from this data that there is quite significant overlap between each of the groups, and actually low voltage is also seen at sites where signal intensity is not high. Next, what about histological data? Well, surprisingly, there is actually extremely little histological data relating to low voltage. This is, in fact, the only study that I have been able to find. And in this study, heart failure was induced in 6 dogs by rapid ventricular pacing for 4 weeks. After 4 weeks, open chest surgery was performed to allow this induced non-contact array to be placed in the atrium. Interestingly, in this study, there was actually no relationship between electrogram voltage and fibrosis recorded with this methodology. In this study, they did, however, find a relationship between fibrosis and conduction slowing, with connexin expression being significantly reduced at sites of low voltage, but only in the presence of significant fibrosis. Now, although the data relating bipolar electrogram voltage to fibrosis is quite weak, there is now quite a lot of clinical data indicating that low voltage is associated with increased severity of AF, including voltage recorded during atrial fibrillation, voltage recorded during sinus rhythm, and voltage recorded during coronary sinus pacing. Indeed, each of these studies found that recorded voltages were significantly lower in patients with persistent AF than paroxysmal AF. So, to summarize the previous section, low voltage has been linked to worse outcomes after ablation and increasing severity of AF, but evidence linking low voltage to physiological mechanisms underpinning an atrial fibrillation substrate is actually quite limited. Furthermore, voltage mapping doesn't seem to be able to describe the whole story. Some patients with paroxysmal AF may have a poor response to pulmonary vein isolation, and some patients with persistent AF may have a good response to pulmonary vein isolation, and different voltage patterns with both high and low voltages may be seen in both groups of patients. These observations have led our group and others to investigate methods that might improve the ability of voltage mapping to identify an atrial fibrillation substrate. One method for doing this that we have been exploring recently is to examine the effect of activation rate on atrial bipolar voltages. There are now a number of pieces of evidence that suggest that bipolar voltage shows activation rate-related properties. Firstly, there is good data to show that voltages are lower during atrial fibrillation than during sinus rhythm. Obviously, there may be confounding factors here, such as wave collision, but fundamentally a core difference between AF and sinus rhythm is more rapid activation of the atrial myocardium during atrial fibrillation. These findings have also been reproduced in a more recent study using high-resolution mapping with Carto3 in stereotaxis, showing again that voltage is higher during sinus rhythm and making the observation that areas of low voltage could be missed by setting the voltage threshold to 0.5 millivolts in sinus rhythm. Clearly, factors other than activation rate might be responsible for low voltage during atrial fibrillation, in particular wave collision and alterations in conduction velocity owing to restitution kinetics. Therefore, to investigate the effect of activation rate directly, we have recently performed voltage measurements during pacing at different coupling intervals from the coronary sinus. The pacing protocol is shown here, and as for our previous study in JAK-EP, involved a 2-beat S1 drivetrain with the S2 coupling interval reducing from 350 to 200 milliseconds. We measured the voltage of only the extra stimulus electrograms and plotted these voltages against the extra stimulus coupling interval before fitting a model consisting of a voltage gradient and a plateau region to this data. Now, using this methodology, we have observed 4 patterns of electrogram voltage. Firstly, there are some sites at which the voltage is constant regardless of activation of extra stimulus coupling interval, and these sites may be both high and low voltage. However, in a significant proportion of sites, electrogram voltage reduces as coupling interval is shortened. In our study, we divided these sites into sites at which the eventual plateau voltage was greater or less than 1 millivolt. But this definition or distinction is, of course, arbitrary. Now, the effect of this voltage attenuation is really quite significant. Grouping the whole study together and plotting voltages of all the extra stimulus electrograms, we showed a significant reduction in voltages when voltage mapping was done at the shortest coupling interval, shown in orange, compared to the longest coupling interval, shown in blue. Importantly, although there were no regions of low voltage by classical criteria at baseline pacing, by pacing rapidly, we could reveal sites at which a significant proportion of electrograms became less than the standard cutoff of 0.5 millivolts. Taken together, we suggest this methodology could arguably provide a protocol to effectively perform an atrial electrical stress test to identify abnormal tissue, although this hypothesis will require further study and correlation with clinical outcomes. So, to summarize, I would conclude that the presence of reduced left atrial voltage is associated with advancing AF disease severity and recurrence of arrhythmia after ablation. However, evidence linking low left atrial voltage to mechanisms underlying AF is actually quite weak. It is important to recognize that voltage recorded in different rhythms, AF, sinus, and pacing, and with different catheters is not necessarily the same thing. And therefore, although substrate-based ablation strategies may show promise for persistent AF, it is my belief that the use of electrograms to identify this substrate should be based on sound preclinical evidence. Finally, the dynamic nature of voltage recordings in the atrium I think is exciting but needs further investigation. Thank you very much.
Thank you, Dr. Williams. Now we move to the last presentation. Will be given by Dr. Luigi Di Biase with the title, Has the left atrial appendage any role in the initiation and maintenance of atrial fibrillation?
Buenos días, muchas gracias por la invitación a esta conferencia. El mío español pequeño, ma la introducción en español. So thank you very much for the invitation, and this is the title of my presentation. These are my disclosure. So I think that I hope at the end of the presentation we will be able to answer this question, which is, should we isolate or not isolate the left atrial appendage? And it's not the topic of this conversation because it was not the question of the title, but I think many of you will like to know, after an electrical isolation, should we occlude or not occlude the left atrial appendage? I would also like to remind all of us that when we look at the United States of America and we look at complex ablation, that the volume of the institution where you perform the procedure is very important. If you perform as an operator and as a center less than 25 procedures per year, your complication rate is high and your success rate is low. In addition, if you look at the United States, 80% of the centers performing ablation perform less than 50 procedures per year. And I think this information is very important. And I know in Europe is very similar. So we start looking at atrial fibrillation as a trigger arrhythmia. It triggers from the pulmonary vein. This is what Isaac Gare showed us in an old trial. We learned very quickly that antrum ablation is better than ostial ablation, and several techniques have been described in the literature. The one that I learned from Dr. Natale include the posterior wall to the pulmonary vein. And why that? Because the posterior wall is and has the same embryologic origin of the pulmonary vein. And if we do believe that the pulmonary vein are arrhythmogenic, we do believe that the posterior wall is arrhythmogenic. And I think after the previous presentation, it's very important to understand, it's atrial fibrillation a trigger activity or it is a substrate ablation? I still believe that it's a trigger and that we need to find more triggers. So the slide that summarizes our work is the following. When you have paroxysmal atrial fibrillation, the majority of the trigger are in the pulmonary vein, and the minority are outside the pulmonary vein. When the atrial fibrillation progresses to persistent and long-standing persistent, the minority of the triggers are in the vein, and the majority are outside the vein. Now, I can share with the previous speaker that there is more scar here, more low voltages, but we still believe that you need to go for a trigger ablation. And these triggers are located in the coronary sinus and mainly in the left atrial appendage. And this is why, if you look at this slide, I show you 20% of the pulmonary vein are not responsible for the atrial fibrillation, even in paroxysmal. This is why when you look at this trial, perfect contact force, success rate no more than 80%. And here, optimal contact force, 85%. So no paroxysmal study shows more than 85%. In my opinion, because that's not the area where the atrial fibrillation is coming from, no matter which best technology you use. And this is why, if you look at this long-standing persistent atrial fibrillation outcome, 20% success rate at 5 years, because when you limit the procedure to the pulmonary vein, and if you look at this slide, when this is long-standing persistent atrial fibrillation, they did only pulmonary vein isolation. The majority of the trigger are outside, so it's easy to expect this kind of outcome. And this is why we called long-standing persistent atrial fibrillation the metastatic cancer of electrophysiology, because if you wait too much, the main source of the cancer is not in the pulmonary vein anymore and is spread out to many more areas that you need to ablate if you want to achieve success. And we have the slide again. So we try to understand when you have to do more than the pulmonary veins in order to reduce the number of redo cases that we do. And in our experience, the group of patients that have the higher prevalence of non-PV triggers are patients with severe left atrial scarring, patients with non-paroxysmal atrial fibrillation, females, patients with large atrium, patients with sleep apnea and obesity, patients with mechanical valve, and in patients with depressed LV function. So these are a category of patients where I would not advise to limit the procedure to the pulmonary vein and to go for non-PV trigger ablation, as I will try to explain. So our technique is a thoracic vein approach, the non-PV trigger approach, which includes the pulmonary veins, the superior vena cava, the left atrial appendage, the coronary sinus, the ligament of Marshall, if you want, consider that, and posterior wall. So where the left atrial appendage? We go back here, we started here from the pulmonary veins and as a trigger, this is a slide that I shared with Professor Cook here. You can see that there is far field between the pulmonary vein and the left atrial appendage. So are we really sure that all the trigger that we have seen from the pulmonary vein come from the vein and don't come from the left atrial appendage? I think we should rethink about this. And also, I would like to remind all of us that we perform an empirical pulmonary vein isolation. We do not ablate only the vein that are responsible for the arrhythmia, but we perform an empirical pulmonary vein isolation. And this is why we have designed the trial that I will present later. Also, this is just a slide showing you, this is the appendage, this is the vein. So it's easy that if you don't record from here, a trigger coming from the appendage is lost and is considered to come from the pulmonary vein, the left superior pulmonary vein. Also, there is histopathological evidence of automaticity cells in the left atrial appendage that might explain why this structure is arrhythmogenic. So, how we learned this? In 2010, we were already able to achieve durable PV isolation. So we were receiving patients with isolated PVs in atrial fibrillation in the lab. So we had to say, we had to do something here because the veins are isolated and the patient is in atrial fibrillation, so the vein comes from some other area. So out of 4,000 patients in 987, we did isoproterenol test and no firing from the appendage in 73, but in 27 we could see a firing from the left atrial appendage. All these patients had isolated PV, and you can see that 18% were paroxysmal, so the minority, but a few of them still have appendage, while the majority non-paroxysmal. And then we did ignore the appendage, focal ablation versus isolation. And these are the outcome. Focal ablation basically as bad as not doing the appendage, while isolation the best outcome. And how we do that? By placing the circular mapping catheter at the ostium, at the base of the left atrial appendage, and we burn around the vein, being being very careful not to pass the circular mapping catheter when performing this ablation in sinus rhythm. And you can see here we go on the earliest activation, then we achieve delay in the left atrial appendage with isolation of the left atrial appendage. I would also like to remind you that many of you perform extensive ablation when there is redo, that you can isolate the appendage without knowing it if you don't record it. And this is an example here. The operator is performing mitral isthmus block or ligament of Marshall ablation. The last here is recording the appendage. If you don't have this, you will not know it. And here you can see appendage isolation while performing coronary sinus or posterior wall ablation. Same, if you are performing epicardial ablation in the coronary sinus, if you don't record with the circular mapping catheter, you can see here that there is appendage, and while burning here in the mid-coronary sinus, you achieve left atrial appendage isolation. So you may achieve left atrial appendage isolation without knowing it if you don't record the left atrial appendage. It's a difficult structure to isolate, and this nice paper from London shows very well how thick anteriorly is this structure. So it takes time to isolate the appendage. Many techniques have been described. This one, when you go anterior to the appendage and you try to do a line, in our view are more arrhythmogenic, are more prothrombotic, because you cause a lot of mechanical dysfunction in the atrium than the way we perform it going around the appendage. And in this paper by Dr. Bordignon here, he showed very well that they were able to achieve appendage isolation after a learning curve that is not that bad, with some higher number of complications at the beginning, but not bad after T3. So we designed, for this reason, the BELIEF trial, which was a randomized trial where 170 patients with long-standing persistent atrial fibrillation were randomized to an extensive ablation plus empirically the left atrial appendage versus an extensive ablation alone. And this were the summary here. You can see posterior wall coronary sinus in both groups, but only in this group the appendage was isolated, while here was not isolated. These were the outcome, which were 56% versus 28% in the group that did not do the ablation, and by including the ablation at redo, 76 versus 55. But again, this was after multiple procedures, and the control group had an extensive ablation to start with, including posterior wall, coronary sinus, and superior vena cava. So these are important information to remind. Is this reproducible? Can other people do that? Well, we have many trials now. Iseguer and Nosini spoke about localized reentry within the left atrial appendage. You can see how extensive was their ablation in the appendage. We have case report of refractory arrhythmias that only terminated with excision of the appendage. We have the Lariat device in the US, which showed a reduction of the burden of the atrial fibrillation from 65 to 39 when closing the appendage with the Lariat. That is a mechanical device that creates mechanical electrical isolation of the appendage. This is a case report published with the termination of the atrial fibrillation to sinus rhythm and a good outcome at follow-up. And for this reason, in the United States of America, there is the AMAZE trial, which randomized patients to closure of the appendage with mechanical isolation with the Lariat device plus PVI versus PVI alone. This trial will confirm our results. Probably the criticism I had to this trial is that they will not allow coronary sinus ablation and posterior wall ablation, which are, in our view, important factors to achieve success. Many other trials. This is from Korea, Dr. Kim. This is Dr. Paniker from London. Again, I showed you this slide before about the complexity of doing this, but again, when the appendage was included, the success rate went from 62.5 to 9%, 95% in persistent patients. And this is an example done with cryoablation, which is now available to perform appendage isolation. And here, success rate with one procedure, 65%. And this nice paper from Turkey, where 100 patients were match control, PVI alone with cryo versus PVI alone plus empirical appendage isolation in patients with persistent atrial fibrillation. Very clean study, no lines, no posterior wall, nothing else. PVI with the cryo, PVI plus empirical appendage in the control group. And this is the slide that summarizes the trial. Success rate you can see here, very good with PVI plus left atrial appendage isolation, almost similar to the success rate of the ICE and FIRE in paroxysmal they achieved in persistent. So many trials together. You can find the literature that if you do this surgically, the outcome is not that good, and this is one of them, and this another one by Dr. Romanov showing that it's a small randomized trial. We have an explanation. When surgically you try to remove or excite the appendage, you leave a stump, and the stump of the left atrial appendage, because the surgeon needs room to suture the tissue, the stump of the left atrial appendage is arrhythmogenic. This is why, for us, that way is not the outcome that we want. Actually, it's easy for us to isolate an appendage where there is a stump rather than going for full isolation. And we also reported this in an abstract that the stump of the left atrial appendage is arrhythmogenic and needs to be isolated. Also from surgery, if you look at this mitral valve trial, when they did ablation of the appendage and the appendage was removed, these are the patients that the most achieved sinus rhythm and follow-up when compared to the patient that did not remove the appendage. And so this is another good information that comes from surgery. All this data together, there are two meta-analyses published in the literature, one of Jack and P that I'm not going to go through. They showed here anyway cryoballoon, radiofrequency, and appendage isolation. And then we also performed this with one of my junior attending in Montefiore. Here you can see that all type of recurrence favors left atrial appendage isolation for all type of recurrence, from stroke risk and from many other parameters. So there are meta-analyses performed. From the meta-analysis, you can see that to achieve an appendage isolation, around 20-25 more minutes or RF are needed to achieve that to the index procedure that you currently perform. So it's longer procedure at the beginning, but it's possible to be done. And so we concluded that regardless of the method and technique utilized, you can achieve appendage isolation, and this does not increase the risk of stroke at follow-up. The questions to be answered is, can you stop oral anticoagulation after an electrical isolation? What is the stroke risk? And should we occlude the left atrial appendage after an electrical isolation? I think I have room for the discussion about this. This was not the topic of the presentation. So my conclusion is that identification of triggers outside the antrum using a high dose of isoproterenol is important to achieve long-term cure. Left atrial appendage and coronary sinus isolation appear the most relevant triggers to ablate to achieve freedom from arrhythmias, especially in patients with non-paroxysmal atrial fibrillation, and this should be done even if you see PAC from this structure and not only firing. And stroke risk following left atrial appendage electrical isolation may occur recurrence of just core, and most likely when patients are off oral anticoagulation or not compliant to oral anticoagulation or under the care of unaware physician about the left atrial appendage that decide oral anticoagulation discontinuation. Therefore, I do believe that left atrial appendage electrical isolation should be considered a risk factor for TIA stroke, and indication for LA closure device or lifelong oral anticoagulation should be considered irrespective of CHA2DS score. Thank you very much for your attention.
Thank you, Dr. Di Biase.